All right, I realize we have already talked about this slide, but there were a couple of points that I don't recall mentioning. So again, it could be because I'm just fading into darkness even as you watch. But so make sure you know the definition of ESV, EDV, stroke volume, know the relationship between all three of those parameters. And then I don't know if I mentioned this or not, but you also need to be familiar with the ejection fraction, which is the percentage or proportion of the EDV that is expelled from the ventricle. All right, and so that's usually expressed as a percentage. And what you're going to find in your clinical coursework is that it needs to be, in a normal individual, it needs to be greater than half. In fact, it should be anywhere from 55 to 70%. But if it's less than 50%, there's usually a problem. But that's ejection fraction. Remember, the others are volumes. By the way, we need to work through that in just a moment, or a little later. But this is a percentage. And there's also something called cardiac reserve. I think we talked about this a little bit. Your cardiovascular system has the ability to sustain you through great stress. That's how, of course, you're making it through the first semester of the PA program. It also has the ability to enable you to withstand physiological stresses, illness, and so on. And that is termed the cardiac reserve, your ability to draw upon additional capability, especially in strenuous exercise, that you don't need in the normal day-to-day affairs activities. All right, so let's go back to where we left off. I think we're talking about heart rate. A lot of this, we're just really introducing a few numbers that sort of give us a sense of normality and what to expect. Of course, in your patient's heart rate will vary with a lot of factors: the age of the patient, the fitness of the patient, the nature of the patient's disease, and so on. It's going to change quite a bit developmentally. Neonatally, relatively high, in some cases up around 115 or more. It tends to decline as we mature, and then as we pass into or move into advanced age, the heart rate tends to increase again, in part because of the declining cardiac function, and that would be a compensatory response. The maximum heart rate is more of a clinical issue in here, but generally, your heart rate should be less than certainly 220. That would be an outward maximum. It tends to decline as we age. Indeed, if the heart starts beating at a very high rate in the elderly person, that won't last very long. In your clinical courses, you'll learn that the cardiovascular system at elevated heart rates will go into something called decompensation. In many cases, that's irreversible. We have talked about bradycardia and tachycardia. For here, let's just say we're talking about a range of 60 to 100 being normal. You may learn something very different in the pathology, but we'll say anything lower than 60, a resting heart rate less than 60, would be indicative of some measure of bradycardia. Anything greater than 100, depending upon the patient history, depending upon a variety of circumstances. For example, I've always been tachycardic. It's always been relatively high. It's always comforting to know when I hear these science reporters say, you have exactly how many heartbeats in your life, no more, no less. So, of course, the more rapidly your heart beats, the shorter your life is going to be, according to these authorities. But in any case, tachycardia may result from everything from endocrine, autonomic. Again, a person with a cold is going to have an elevated heart rate. Respiratory distress is going to elevate heart rate. So any number of factors can be responsible for elevated heart rate. Now we need to talk a little bit about some general physical principles of cardiac contraction, and we'll do that both in this unit and in the next unit. And it says here that the heart rate and cardiac output tend to increase or tend to parallel each other with exertion. The idea here is that as your heart beats more rapidly, it also beats more forcefully. And so as a result, you would expect blood pressure to go up, cardiac output is going to go up. But the problem is that's only going to be true for a limited period of time. Eventually, if the heart rate exceeds a certain point, there will be insufficient time for the blood to fill the ventricles, and it really doesn't matter at that point how forcefully the ventricles are contracting. So make sure you understand that when we talk about heart rate and cardiac output varying with each other, very directly with each other, at some point, if heart rate increases beyond that critical value, cardiac output will tend to drop, and that's simply because there's insufficient filling time for the blood to pass into the ventricles and then be discharged from the ventricles. Heart rate is regulated by the cardiovascular centers. We talked about these when we talked about the brainstem. You can sort of see them in the position chiefly in the medulla there. But the heart rate is regulated by a variety of reflex responses, and you have some of them listed here. I think all we want is for you to have a general appreciation of how they work, and they're explained in more detail a little later in some cases. In other cases, we'll address them elsewhere. But you have baroreceptors in the carotid sinus and the aorta, and in fact, in other places in the cardiovascular system. What does a barometer do? Measures air pressure. So here we're talking about a baroreceptor measuring blood pressure. And so obviously, if peripheral blood pressure is elevated, if you were in charge of things, you want to bring the blood pressure back to homeostatic values, how would you correct for that? How could you correct for elevated peripheral blood pressure?
Vasodilator.
Yeah, lowering the heart rate. So the heart rate is going to be regulated by peripheral blood pressure. By the way, as we think about all these questions and all these relationships, remember our fundamental premise. The heart is the central, and that's not a trivial word, it is the central pressure generator necessary for flow to occur. The flow of blood, we talk about a volume passing across a certain point in time. We have very formal definitions for these terms. So if we have an elevation in peripheral blood pressure, you certainly don't want an elevation in distal central pressure if you're trying to maintain homeostasis. Chemoreceptors can also regulate heart rate, chiefly in response to the carbon dioxide oxygen ratio. In general, this is a little bit complicated for our discussion now, but if O2 levels go down, the heart will try to compensate by increasing perfusion. So we'll talk more about this when we talk about the respiratory system. The brainstem also responds to increased activity. We talked about the proprioceptors. What are proprioceptors? Yeah, these are for example, the Golgi tendon organs, the muscle spindle fibers that respond to changes in muscle contraction, muscle tonus, and so on. So the feedback from those sensory receptors in the muscle tissue also will tend to regulate heart rate. Again, heart rate is going to increase as activity increases. And then just anticipation of the test on Monday. Just the fact that I mentioned it probably increased your heart rate. That's limbic activation, emotion, stress. Can do the same thing. And as we indicated in the previous discussion this morning, a lot of this regulation is achieved through autonomic reflexes involving both the parasympathetic and the sympathetic. We talked about elevation or depression of heart rate. As you're sitting there right now, which division of the ANS is primarily influencing or controlling your heart rate? The parasympathetic. And if heart rate is actually increased, it's important to understand that can be done in two ways: by reducing parasympathetic tone and by increasing sympathetic activation. I mentioned the term tone. We've used this term before. Tonus is a mild persistent activation that refers to everything from skeletal muscle to GI tract innervation. Normally, with respect to regulation of heart rate, vagal tone is going to be more important than sympathetic tone, certainly in times of rest and in times of normal homeostasis. Remember, in the absence of parasympathetic innervation, the SA node is going to take your heart rate up around 100 beats per minute. It's going to be dependent on a lot of factors, but take, for example, you tell me you have a heart transplant patient. What is what is their heart rate likely to be? Heart transplant patient. Yeah, it's likely to be higher than normal. There are a lot of factors, and especially they have all sorts of ways of addressing this now. In fact, well, we won't get into that now. But yeah, it's typically going to be elevated, and it may well be close to 90 or 100 beats per minute because those autonomic pathways have been removed. And then this morning we also talked about the cardiac plexus. So you know that's that interwoven spider web of sympathetic and parasympathetic fibers that sort of wraps around the trachea and the primary bronchi there, but it also extends anteriorly and posteriorly. Sympathetic activation, parasympathetic activation, just be aware of not only the pathways that we discussed this morning, but also be aware of, for example, if we see reference to alpha and beta receptors, we know that you're talking about sympathetic activation. In terms of heart rate, the more important of the receptors is the beta-1 receptor, which we talked about in our discussion of the autonomic unit. So a beta blocker, among its many other effects on the body, would generally act to lower heart rate, all else being equal. Now, we talked about parasympathetic innervation. We talked about this morning. You should know about the potassium ACH channels we talked about. Acetylcholine, all else being equal, is going to act to depress heart rate. Decreasing parasympathetic activation, as we indicated a moment ago, will elevate heart rate. And all from and by the way, be familiar with this term. I think I might have used this on the quiz. What do we mean by sinus rhythm? Are we talking about the coronary sinus? What are we talking about? The sinoatrial node is what we're talking about here. So just be aware of all this variant terminology, and none of it's particularly consistent. Now, there's an error here. And you tell me what the error is. It says the PNS also slows conduction of APs through the AV node. What do we mean by that? What does that mean to you personally? What do you mean by slowed conduction?
The AV has the pause when received from the SA node.
All right, and when it says it slows conduction, though, I just want to make sure you understand that we're not talking about, remember we had those three words before. You're exactly right. And we're talking about an even greater slowing. Remember we talked about chronotropy. And what was the term that we used to describe conduction speed? Does anybody recall? One you need to know. Exactly. Dromotropic. Remember the third one? You got to be careful with the spelling here. Ionotropic means something else. This is inotropic. If we had more time to talk about the cell biology, we could have talked about the ionotropic. This is inotropic. And so as we go back to this this little paragraph here, what is the error? This should be dromotropic. Now, in reality, if I were to get this from a textbook, in most cases, in most cases, dromotropic effects alter chronotropic, but technically the correct term here would be dromotropic. And if we have time, we'll talk about that later. There's a nice little table here that says major factors increasing heart rate and force of contraction. I would encourage you to work through these and make sure you understand the argument. Okay. So these are factors that elevate heart rate and contraction. So we're talking about both a chronotropic and an inotropic effect. Cardioaccelerators, in general, when we talk about cardioaccelerator, and that's a term you should be familiar with because you see it in the medical literature quite a bit. We're generally talking about sympathetic activation. So the sympathetic stimulation would promote both an increased contractility and heart rate. Proprioceptors, we saw this before, increased activity increases cardiac output. Chemoreceptors, again, it's the CO2 to O2 ratio that is most important. As the CO2 to O2 ratio increases, we'll talk about this in our respiratory discussion, as that ratio increases, the heart tends to compensate by pumping more actively. Baroreceptors, if blood pressure drops, the heart will try to compensate by beating more efficiently, beating more forcefully and more rapidly. Well, we indicated the limbic activation. Again, you're thinking about your date on Friday or Saturday night, and your heart rate goes up. Catecholamines, well, that takes us back to the cardiac accelerator here, because those catecholamines in most cases are going to be released through sympathetic activation or through either through the endocrine system or through the autonomic nervous system. Remember in our discussion of the endocrine system, thyroid hormones also increase not only BMR, but to elevate cardiovascular function, cardiopulmonary function in general. Calcium is a little bit complicated. We won't worry about that here. That has to do with the resting membrane potential and the threshold. So yeah, be familiar with these. We won't worry so much about these. Mm-hmm. And then you have another table looking at the same things from the opposite direction. So I really only needed to put one table in there, but you have two for the price of one. Okay. All right, let's talk about a few more just very basic physiological terms. We know the definition of stroke volume. Somebody give me a definition of stroke volume. What is stroke volume? It's the volume of blood discharged from the ventricle with contraction. Good. So we have a few more terms that involve regulation, determination of stroke volume, things like preload, contractility, and afterload. So by preload, and by the way, the proper definition, and we can speak properly or we can speak sort of in the vernacular here, but when we talk about load, we're talking about a force. So as we discuss both preload and afterload, properly speaking, you should understand those terms to refer to a force. So preload refers to the force necessary to discharge the volume. It's basically the force necessary to discharge the EDV, basically the force necessary to discharge the blood from the ventricle. Now, you can see, in fact, I've sort of made the tautology here between preload and EDV. EDV is a volume, preload is a force, but by preload, what we mean here is simply the more blood that is in the ventricle, the greater the force necessary to discharge that volume. Obviously, if I'm picking up a weight, I have to exert more force to pick up a heavy weight than a small weight. Same idea here. If I have a larger volume of blood, in order to expel that or discharge it, the ventricle needs to contract much more forcefully. So that's preload. And so preload is going to be directly related to, or a function of, the volume of blood in the ventricle. Now, according to the Frank-Starling mechanism, the heart intrinsically, without any fooling around, no assistance from the endocrine system, no assistance from the autonomic nervous system, the heart intrinsically has the ability to regulate the force of contraction based upon the preload. And according to the Starling's law of the heart, as EDV increases, the force of contraction or contractility increases. So that's kind of fortunate. That's kind of nice. Otherwise, we'd have a problem. So what we're saying is, the greater the venous return, the greater the volume of blood in the ventricle, the more forcefully the heart will contract to discharge that blood. And it happens, the heart does this on its own. It doesn't require any additional thinking or assistance from an outside system. This is entirely intrinsic. Now again, this is only going to work up to a point, but that's the general principle. Don't worry about this one, but you should be able to work through the two top graphs there and see if you can interpret those. By the way, the graph at the top left here is cardiac output with respect to RAP, which is right atrial pressure. Some of you may have a slightly different understanding of that term, but in here it's right atrial pressure. And so what is this graph telling us? the more rapt you listen to. No, what is the graph telling us?
The higher the pressure, the higher the output.
All right, so be careful. As RAP increases, cardiac output increases up to a point. All right, so what do we mean by right atrial pressure? We'll pursue this in more detail later, but we're just talking about the pressure of the blood that is pushing against the walls of the atrium, the right atrium. Would you expect that pressure to be high or low, let's say relative to ventricular pressure? Low, very, very low. And so, in fact, look at this, look at our units, it's 0 here. But what we're saying is that as right atrial pressure increases, cardiac output increases. What's the principle that we just discussed that might help to explain this phenomenon? All right, what would cause right atrial pressure to go up? It's going to get more complicated very shortly, but what would cause right atrial pressure to increase?
Volume.
Yeah, more blood coming into the atrium. As I say, it's going to get a little more complicated there. But as we increase that pressure and increase it, if we assume there's a direct relationship between pressure and volume, as the right atrial pressure increases, then cardiac output increases. Unfortunately, this only works for a while, and it goes the other direction. Things get impossibly complex very shortly. All right, so that's preload, and you can think of, as far as I'm concerned, you can think of this as the volume of blood in the ventricle, but in reality, it's the force of contraction necessary to discharge that volume. It's just the two are directly related. Now, perhaps the more difficult concept is afterload, and it's a relatively trivial concept, but I seem to have trouble explaining it. Afterload, very simply expressed, is the resistance imposed by the entire cardiovascular system to the discharge of blood from the ventricle. So the ventricle, if I want to Trenton seat here, and I'm thinking I'm wanting his seat, all right? He's recalcitrant, as you know. He's a difficult and refractory individual, and he's not going to allow me to have his seat. So what am I going to have to do to get his seat? I'm going to have to push him, and that's going to push God, and so on. And as a consequence, it's going to take a lot of work. Eventually, Luis is going to be just knocked out, probably through the wall, which is really going to increase I haven't done that in a long time, but I'm kind of relishing the prospect. All right. But you get the idea. In order for me to move that column of blood, which is in the aorta, in the arteries, in the arterioles, in the capillaries, in the venules, all right, that's going to take effort. It's going to take energy. The physical term is work. And the more resistance they present, the more forcefully the heart, the ventricle have to exert. That resistance is the afterload. Another way of thinking about this is TPR, total peripheral resistance, but it's actually a lot of different factors. So is that clear? The preload is what I have to discharge. The preload is the volume of blood that has to be discharged. The afterload is the resistance, we can use the left side, the resistance imposed by that aortic valve. When I discharge that blood out the aortic valve, we know the pressure in the ventricle has to exceed the pressure in the aorta. That pressure is resistance. It wants to come this way. I have to push it the other way. That's my afterload. So we all understand the general distinction between the two.
So it's the work against the systemic diastolic pressure?
So you say, yeah, I don't have any trouble with that, as long as you understand that while that's true, it's not, this afterload isn't really relevant during diastole.
Yeah.
Yeah. Okay, I would agree with you. It only becomes relevant cardiologically during systole, when that pressure has to be.
To overcome an opening.
Yes.
Does the preload just refer to the atrium?
No. We're only talking about the ventricle here. That's not this. So this is only referring to the atrium.
Because with the graph, it's like
Oh, I see what you're saying. So you're talking about
so
the.
why would that be the difference?
Yeah. Okay. So let's. Okay. So if we have. Oh my goodness, I can't draw. I backed myself into a corner here. So
No, man.
No, that's not going to work either. So let's do it this way. You would agree that when that AV valve here is open, the blood is just going to flow right on through, right? All right. But you would agree, and we can say this is the vena cava here, and this is the atrium here. Under normal circumstances, as I say, things are going to get complicated shortly. But as the blood returns at minimal pressure into the atria, basically the pressure in the vena cava is going to be equivalent to the pressure in the vena in the right atrium. There shouldn't be much difference, right? And so what we're saying is, and by the way, this pressure, strictly speaking, as we're going to learn later, is called central venous pressure. This pressure and this pressure should equal RAP. So what we're saying is CVP should be proportional to RAP. And that, what we're saying is the pressure of the blood returning to the atrium is, for all intents and purposes, equivalent to the blood that's passing into the ventricle. And the only time we have that little atrial kick at the end, but that's irrelevant. It's really not important for our considerations. So when we talk about RAP here, we're only talking about the filling pressure. And that filling pressure is very, very small, in the single digits. I want to make sure you understand what I'm saying. This RAP refers to the pressure in the atrium that's pushing against the walls of the atrium, but it's also pushing the blood into the ventricle. And what we're saying is, if I increase this pressure, more blood coming in, then there's going to be a greater volume of blood in the ventricle. That's all we're saying. As I say, we've got to make it a little more complicated later. We've talked about sympathetic nervous system. Sympathetic nervous system acts on chiefly beta receptors, and we talked about alpha receptors for heart rate, beta receptors to increase contractility. But either way, the sympathetic activation is going to increase both rate and force of contraction. It's going to have both a chronotropic and an inotropic effect. And then we've seen this word before. We talked about trepo with respect to skeletal muscle. Remember, the idea there was with each successive low-frequency contraction, the force of contraction would increase up to fatigue. Trepa in cardiac muscle means something a little different. It's basically saying that heart rate and contractile force are directly related. We talked about that before. That's an intrinsic regulatory mechanism. That's in part related to Starling's law. But at some point, it's going to break down. Why does it break down? Why is trepa not a universal principle that applies to all frequencies of heart contraction?
The volume will go down eventually.
Right, because as the rate goes up, there's insufficient time for the blood to fill the ventricle, so cardiac output is going to decline. So trepa only works as we elevate heart rate from a normal homeostatic level. As we get to a certain point, let's say around, I think depending on the age of health and fitness, 180 close to 200 is good. That's no longer will apply. All right, we've used the term inotropic to describe any type of therapy or factor that influences the contractility or force of contraction. A positive inotropic increases the force of contraction. A negative inotropic decreases the force of contraction. And hopefully it's evident to you that if we increase the force of contraction, we also increase stroke volume and decrease in systolic volume. What is in systolic volume? It's the volume of blood remaining in the ventricle after contraction. So if I increase the force of contraction, all else being equal, my ejection fraction should increase, the stroke volume should go up, the in volume should decrease. All right, so we've already talked about this. Sympathetic activation is generally a positive inotropic. Parasympathetic activation is generally a negative inotropic. And in part, I don't know that it's terribly important for our very general consideration, but sympathetic activation is predominantly upon the ventricles. Parasympathetic at least with respect to its regulation of rate, is more important in the atrium. So you have a list of positive inotropics here. Some are going to become clearer as we continue our discussion later, but let's just work through some of these. Catecholamines, again, what should come to mind there? Positive inotropic. Sympathetic activation, right? Autonomic sympathetic activation. What is a beta agonist? We were talking about beta blockers a moment ago. What's a beta agonist?
Normal action of the beta.
All right, so an agonist would basically be anything that binds to that beta receptor and produce the normal physiological response. And you're going to have at your disposal just a cornucopia of beta blockers and beta agonists that you can use to help your patient's cardiac function. And sometimes you won't know which to use. You have a patient in cardiac. You have a patient in congestive heart failure. Patient in congestive heart failure. Are you going to prescribe a positive inotropic or a negative inotropic? Congestive heart failure. Heart's barely beating. All right, positive. What's the problem with the positive? Right, you're going to increase cardiac function, but that poor heart is on its last legs. So negative inotropic may give them more time, but that greatly diminished quality of life. Again, these are the decisions you have to make. You make the big bucks. I just sit here and talk. So angiotensin, we'll talk about this later, but this is a hormone released in response to a renal hormone. But it also it has a number of functions. It tends to also, through its activity on the autonomic nervous system, also increases heart contractility. And then there are things like stimulants like caffeine, theophylline, there's digioxin, which affects conduction, that also tend to elevate the concentration of calcium in the cardiac cells, and they too can act as positive inotropics. So look at the table here. Let's just see if everybody can understand the terminology. It says, the table is labeled factors affecting stroke volume. Factors affecting stroke volume. And so stroke volume is raised, or at least preload is raised. If we understand the figure here. So if the relationship between stroke volume and preload is raised due to increased end-diastolic volume. So preload, remember, is a force of contraction. If we increase the end-diastolic volume, what is the principle? What is the law or principle we talked about that would increase contractility? Starling's law of the heart, intrinsic. If you increase the volume of the ventricle, the ventricle contracts much more rapidly. And if it does that, it's also going to increase stroke volume. Let's talk about afterload. All right, as we increase afterload, is it clear to you that would increase in systolic volume? And somebody tell me why. What is afterload? The resistance. So if afterload is elevated, why would ESV go up?
Spending more time contracting.
The ventricle is contracting, pushing the blood out the door here. I've increased the resistance, therefore I cannot push as much. Therefore, is it clear to you that that's going to increase the volume of blood that remains in the ventricle? And then decreases stroke volume, because these two are inversely related, right? Stroke volume is going to decrease, and systolic volume is going to increase as we increase the afterload. So be sure you understand the relationship between these terms and the consequences down here. And you have several figures here trying to summarize some of the things we've talked about with respect to preload, contractility, and afterload, and their effects on EDV and ESV. Hopefully these same thing here. This figure is just a simplification of this figure. These are factors that influence heart rate. These are factors that influence stroke volume. The product of the two is cardiac output, so you can see the contribution of each of these, everything from autonomic innervation to hormones and so on that would affect either heart rate or stroke volume. With respect to the evaluation of cardiac function, there are a number of procedures and processes that you can use. You'll look, for example, the arterial and jugular pulse. We'll come back to the jugular and venous pulse in just a moment. We talked about auscultation. You'll learn to place your stethoscope at various points about the perimeter of the heart and listen for valvular activity, for example. Electrocardiography, we talked about the EKG. This is a fairly non-invasive and important record of the electrical activity of the heart. Echocardiography is, again, a sort of a sonographic procedure. This is very important in establishing, for example, everything from whether the aorta is enlarged to also assessing the relative health and functionality of valves. We've looked at a couple of cardiac catheter procedures where, for example, we looked at that pacemaker that was introduced into the leg and then taken into the heart, so to correct for an arrhythmia. Catheterization. If you actually wanted to measure the blood pressure correctly, how would you do that? You're going to learn about the brachial blood pressure.
Arterial line.
Yeah, you'd actually have the implication there being that you'd actually have to go somewhere close to some point in the heart and actually make what's called an impedance measurement, blocking a structure and measuring the pressure at that point. A lot of fascinating new procedures involving pulsed Doppler. Anybody want to explain Doppler effect for us real quick?
You're able to hear the sounds of the pressure.
All right, so you're talking about sound. Yeah, the classic example is that you're standing at the train station. You're standing at the train station now because that's what this class is all about.
Mm-hmm.
But the train station, as the train approaches, the pitch of the whistle changes, or a car horn does the same thing as it approaches and leaves you, and that's because the frequency, the emanation of the sound is increasing in frequency as it comes toward you. You're adding the speed of the sound plus the speed of the vehicle moving towards you, and as it moves away, the distance is increasing, so the pitch drops. All right. Likewise, there are all kinds of Doppler procedures in which the little device will be looking, you'll send a little beam of light. Sometimes they do it in the capillaries in the skin of the tip of the finger. And what that device is measuring is the reflectance or transmissivity of the light at certain frequencies. For example, a red wavelength that would be associated with red blood cells. And so they can make all sorts of inferences about how rapidly those red blood cells are making. And now, oxygen carrying capability, and there's even a new test. It's in clinical trials now. At least I don't know if it's in clinical trials. It's in trials. It's a new method for measuring glucose. It's a test for diabetes, non-invasive, involving pulsed Doppler. And basically all it's doing again is measuring the wavelength of light, because the wavelength changes with the binding of glucose to the red blood cell. But that can be used to get some fairly close measure of blood glucose concentration, but also oxygen carrying concentration and so on. We've already talked about the ejection fraction. Again, this is a percentage, should be greater than 50%. So all of these are useful measures of cardiac function. Just be familiar with the terminology. We've talked about auscultation. I'm not going to ask you in here where you should place the stethoscope to assess the specific semilunar and AV valve activity, but you can see, you will learn very precisely where to place those things. We talked about the heart sounds, the first and the second heart sounds. The first sound is associated with the closing of the AV valves. The second sound is associated with the closing of the semilunar valves. Oftentimes, if there is stenosis or there is a problem with the valvular activity, for example, regurgitation or valvular insufficiency, that's manifest as a murmur, and you will learn to hear different types of murmurs and the characteristic qualities of sound associated with those. But any number of things will affect what you hear in your stethoscope with respect to the heart sounds. everything from breathing to physical activity, any number of things can have an effect on these and both change the rate of the auscultation, the rate of the heart, and also the quality of the sound. We won't worry too much about S3 and S4 in here. These are phenomena that may or may not be present, thought to be associated with, for example, movement of the heart in athletes or in some individuals that have enlarged anginic hearts, enlarged hearts, perhaps abnormal movement in the atria. Athletes' hearts, for example, tend to have a fairly characteristic quality that is sometimes different from those of normal individuals. All right, so we've already talked about that. Good, we're finished. Let's take a break and we'll put the next unit there.